This is Facts from the Frontlines, St. Michael's Hospital Foundation's inaugural COVID-19 podcast series, where our world-leading experts provide the knowledge you need to keep you safe and informed.
Welcome, everyone. It's my pleasure today to welcome Dr. Carolyn Snider to this telecast. She's the chief of the Department of Emergency Medicine at St. Michael's Hospital, which is, is part of Unity Health Toronto. So, Carolyn, thank you so much for giving us some of your time. I know how busy you are. And these are obviously unprecedented times with a world pandemic upon us. We've had to radically and quickly alter the way we deliver care, and we'll have to do that until this is over. So all non-essential care at St. Michael's has been postponed or moved out of the hospital. So actually, the only real point of entry for patients now is through the emergency room. So Carolyn, wanted to chat with you about that. So actually, my first question, Carolyn, relates to the fact that probably many of our listeners actually haven't even been in our emergency room or even maybe any emergency room. So maybe you could just start by telling us what the St. Michael's Hospital emergency room looked like before. Like what's the emergency room like? And then we'll get into what it's like today.
Okay, so we had the before COVID emergency department where when patients came in, they walked in, they came up one ramp, and if they came by ambulance, they came out up another ramp, unless they came by helicopter, in which case they landed on our amazing helicopter pod, came down by elevator. And they came to our triage space and hopefully didn't have to wait too long to be then moved to either a bed in the acute area or in the ambulatory area or in the mental health area in our emergency department. And that was all based on the triage at the door, and there were emerge docs in all three areas available to see a patient if they were able to be discharged, of which usually about 70 to 80% of our patients are discharged from our emergency department. They would be. And then the other 20% are referred on to one of our consultant groups in the hospital. And sometimes that discharge meant going to an ambulatory care clinic in the next few days or in the next few weeks for follow-up care with one of our consultants as well. Then there became COVID times, and we're in the early COVID days. And although we're all working 16, 18 hours a day preparing for it, it is busy. And what this has meant is we've changed a lot in our emergency department. We've gone from going up two pathways to one. We need to have a screener right at the door, and they're in full personal protective equipment, wearing a mask and a visor and a gown and gloves. And they ask every person that comes through that door, whether they're a patient or a patient's family member, or the paramedics or the police officers potentially bringing somebody in. They ask everybody about a fever, shortness of breath, cough, any of the symptoms that we're screening for around COVID. And we immediately put somebody into the potentially COVID box versus potentially not COVID box. And that helps us streamline what areas of the emergency department they go to and what they do. Some patients who are walking in right now that are coming in with very, very mild symptoms are able to be redirected across to the COVID assessment center. And that was an incredible feat at St. Michael's Hospital. Those of us in the emergency department have been living and breathing this for now about 9 weeks or longer, knowing this was coming our way, and we had these grand scheme ideas. And so we started sketching these out a little while before the province came forward and said, let's have some assessment centers. And so we had these assessment centers all ready to go. And our hospital was fantastic about taking the models that a bunch of us had been working on, and we worked closely with family practice to put up this assessment center. And I'm sure you've heard it was built overnight on a Saturday night, and by the Monday morning it was up and operating, having done some in situ simulation with our in situ lead, Andrew Petrosoniak, and that team. It's been incredible, and it took a major load of us in the emergency department. But in off hours and in other patients, everybody gets asked if they're going to about their symptoms. And if they're still screened positive because maybe they have a new fever or a new shortness of breath, they get streamed through our COVID assessment zone. assuming they're still stable. And that's where they may be swabbed and discharged home, or they may be educated that they don't need a swab and discharged home, or they maybe have that initial assessment and say, yes, we need to see this patient in our COVID positive screened area of the emergency department. Our major emergency department, or acute side, has 3 zones, as well as our trauma center, new trauma bay. And we will usually divert to one of those 3 zones. There's the B zone, there's the A zone, and the C zone. Now that obviously I should say A, B, C, but in fact, the reason I say B, A, C is because B is where we're seeing our febrile respiratory illnesses, i.e. those that have been screened positive for COVID. And then when we don't have any space in that, that's going in, it's overflowing into A. And then right now we're keeping our COVID negative unstable patients or acute patients going into the C zone. And we've done that based on where the hallways are, where the x-rays are, where the elevators are, how we can get people in and out of our department. We do see patients in an ambulatory care setting as well. Those are the people that might have broken an ankle or a wrist or need stitches or may have some abdominal pain, and they're stable. And they're all going into those ambulatory care settings as well, presuming they don't screen positive for COVID. We are now in the stage of planning for if what has happened in some of our neighboring countries and Italy and China. If that happens here in Toronto, we've got plans and we're working extremely hard and long hours with some incredible other people at UHT to make them happen. So that if it means that our emergency department is overwhelmed with a number of patients coming in with potential COVID-like symptoms, we have places to send patients who don't have COVID symptoms or are stable and can walk. And maybe they've got a little cough, but they've also hurt their ankle. We have places planned so that we can divert patients to sort of like an alternative emergency department, a stable emergency department. And we're working very closely with our colleagues in family medicine to staff those, as well as the incredible number of people at UHT that are the behind the scene people that we turn to and say, can you make this happen overnight? And they do. And those are the people that are on our team right now as we plan towards what could happen, we hope doesn't happen, but seeing what's happened in New York and Italy and China and other places in the world, we know we have to be ready.
So what kind of volume are you having now? I mean, in pre-COVID, how many patients a day would you see on average in the Emerge?
Well, it really depends on the day of the week. We joke in emergency medicine across the world that somewhere around 11 a.m. every Monday morning, it's like a Greyhound bus drops 40 patients off all at once. It's amazing. Everywhere across the world, 11 a.m., busy times. So Mondays are always busy, well over 200, but other days are just under 200. In total, we have about 80,000 patients come through our emergency department per year. This last 2 weeks has gone through we've had quite a decreased number of patients come through, and that's what we were told to expect. It's the calm before the storm, and overnight that may exponentially increase. That said, we are seeing an increase across Toronto, an increase in cases of COVID, and the increased number of people needing to be admitted with potential COVID-like symptoms. And we're starting to potentially see patients that are going to need to be in our ICU. And these are the signals that we've all been watching for. And each time we get those signals, meaning an admission or another patient going to the ICU, that means that we push a little harder to get those alternative things ready, like the alternative extra stable ED. We haven't named it yet, but we'll have a name in the next few hours because that's the way we work.
So the numbers actually dipped, and now you say they're actually coming back up. And are those numbers, as they come back up, are they driven by patients who are suspected to have COVID for the most part?
Well, it's a bit complex because the numbers, I don't know that the the volume coming through our Emerge is up. But what we've learned is that once we learned that there was community spread in the Toronto area, it meant that we expanded what we are calling a suspect, or, well, actually we're not calling it a suspect, a person still being investigated for COVID. So we're testing more patients who are being admitted to make sure that they don't have COVID. Initially, when we thought they were just coming from travelers, we only tested them. Now we test anyone with shortness of breath. And so that means that those numbers are higher, but we're also fortunately getting a lot of negative results in the last few days, which is making us feel a little more calm about who is coming through. But we don't know. I don't know. Right now, I know to expect it. I haven't yet seen the huge surge. We're seeing some increases, but part of that is due to how we're categorizing people.
So one of the issues is the testing and
Yes.
The turnaround time to get the results. So you're in Emerge dealing with a patient. My assumption is you don't get the test answer on the COVID test answer real soon. That there's a delay there, but you can help me with that.
Well, that's complex because that has changed almost daily over the last 2 weeks. About 2 weeks ago, every test went to the public health labs. And they, at that time, initially had a turnaround time of about 12 to 24 hours. But slowly we were testing more and more and more patients. And they were the sole source of testing, and they couldn't keep up. At the same time, a number of hospitals, ourselves included, were ramping up to have the equipment to be able to test in-house. And so some of the hospitals have been able to turn that around, and ours as well has now a much faster turnaround time. And so if a patient swab goes to the public health labs, they're still catching up. And I'll use myself as an example. Last Tuesday morning, I woke up with a cough and a sore throat. This was still when the swabs were going to the public health lab. And so I came in, I got my swab, I turned around, went home, self-isolated, and started working on Zoom for 16 hours a day, 18 hours a day. My swab came back yesterday, so at the 7-day mark. However, my colleague the next day had the same symptoms. She came in, hers was then sent to one of the hospital labs that had a 12-hour turnaround, and she was back to work the next day because her symptoms were gone. So we're in this sort of bizarre stage where some people are getting their swabs back 12, 24 hours, 36 hours, and others it's taking 7 days because the public health labs of Ontario are trying to catch up on what was a huge increase of labs about a week ago. We're also across the board, whether at the hospital levels or at public health labs, trying to understand who do we need to know right away. If it's a healthcare worker, we need to know right away because we need to know if they've been at work with sick at all, which we hope not because everybody's being asked to stay at home. If they're somebody who is underhoused, and we have a big population of those patients in our hospital that can't go to a regular shelter because if they have COVID and then they can't self-isolate like I was able to self-isolate for the last week. So we're working with the inner city health associates to try and find places where they can be housed in an isolated way. But they too have had some capacity issues. So right now they're in our emergency department. So they're being prioritized for swabs as well. And very importantly, any of those patients going up to the medicine ward who are in an isolation room right now who have been swabbed, those are also being prioritized. We need to know whether they still need isolation so that we can move them out of isolation to be ready for the patients that are in our emergent isolation waiting for an isolation bed upstairs. I hope that makes sense. It's complex.
Yeah, no, it's complicated, but one of the St. Michael's itself is developing the capacity to do the test now, I understand.
Absolutely.
And are you starting
They've been working overtime. It's not just overtime, like quadruple overtime to make this happen. They're pretty impressive people.
So is that online yet?
We're almost there. There's 2 stages of this. There's the stage where they can do it on the bench top, and then the stage where they use it as with an automated machine. And we're at the bench top stage. And that actually allows us to say to them, hey, we've got 10 people who are homeless, who have nowhere to go, and right now are being isolated in our emerge. Please prioritize them. And please prioritize those 10 people on the floor that are in isolation beds and get theirs tested first, please. And that allows us to keep the flow going because we're all standing ready for if there's a surge, and we need to make sure we don't sort of back up the system.
Understood. What about someone who's got mild to moderate COVID? So they've got you believe that they are COVID or they're suspected to be COVID, and the appropriate care is to send them home. What sort of follow-up is there? What happens to them? Obviously, you're an emerge, right? So what happens? What kind of follow-up is there?
Well, the first thing is there's some wonderful public health resources on how to self-isolate and how long to self-isolate. And that's different than what we're asking, people to do around social distancing or physical distancing. So self-isolation for me was very different than what it will be when I get to go home tonight again, when I get to just social distance with my family. So for the last week, I was on the 3rd floor of our home. I'm fortunate to have a pull-out couch there, a bathroom. I actually am fortunate to have a patio at the back that I was able to get some fresh air. I brought my coffee machine up, and each morning I'd get a little cooler with a few things that would, stay cold. But I couldn't eat meals with my family. I couldn't. My kid would come up to say goodnight to me, and I would give her a karate. What we call our karate kiss, where we do like instead of a karate kick, we'd sort of touch each other's toes. That was our version of self-isolation and maintaining sort of some sort of connection. We played cards on Zoom from my floor to down in the downstairs where she and my husband were hanging out. They brought me meals. I washed them in my own bathroom upstairs. This is what self-isolation means. You're really, truly isolating yourself so that your germs don't get on anyone else. Social distancing means we're a pod. The 3 of us are together, and we're making sure that we don't transfer our germs to the person, even our neighbors, or to other extended families. So that's the difference. So when you get tested for COVID, or you find out you're COVID, or you're presumed COVID, because we now don't test everybody with upper respiratory tract infection, people should assume they actually have COVID if they have a cold. And so those people need to go into self-isolation like I did for the last week. And then until we've gotten through those symptoms, and I think it's been 7 days after you started symptoms and 24 hours of symptom free, and it changes all the time. So I'm going to say this, and maybe we shouldn't put it on the video, but public health has really clear guidelines of when you're clear from your COVID, whether it's a COVID suspected or actually diagnosed or presumed. And so after that, that's when you get to go back to the good old social distancing.
And what do you tell patients? I mean, the worry a patient's worry would be, what if I get worse?
Oh, so we definitely tell patients that if they start to get short of breath, like walking across the room, the same way when you're feeling a little out of shape and you're walking up the stairs and you realize you're breathing heavily just walking up the stairs, that feeling, if you're just walking across the room, that's a good sign to come get checked out in the emergency department.
So they would come back. You would tell them to come back.
And then the other thing, though, is many family physicians, including many of the family physicians at St. Mike's, are doing phone appointments, and there's going to be more and more virtual appointments going on. And I know that we can also try and link in that. Obviously, if it's really urgent, you should come back. But if you're just not sure, linking in with your family physician to have an appointment to tell them some of your symptoms, and they can advise you whether you need to be seen in person or giving you advice as well.
Okay.
Public health can also help too. Public health nurses.
So this type of care is I think difficult for staff. So how are your staff holding up with all of this?
Yeah,
pretty stressful.
It is stressful. I think as a leader, this has been a really important. This will likely be my lifetime leadership challenge, and I am just going to say that I'm fortunate to start with the most incredible, engaged group of healthcare workers that you could imagine. And I work closely with Orla Smith and our senior Emerge leadership team to lead this incredible group of people. One of the things that was very clear to me early on is that COVID is moving so fast. And for those of us that like to have a certain amount of control, it is challenging that exceptionally. And so as a leader, one of the things I've tried to do is listen to each person in my department. And when they bring forward an idea, I ask them if they want to take a leadership role in that. And so of our 32 associate docs, I could probably list 25 of them that have taken on some a big job and some a very small but important job within our department to make sure we lead the area in our response to COVID. And what that's resulted in is an incredibly engaged, very, very, frankly, optimistic and positive group of people that are really feeling ready and confident that we're in the right group of people in the right space, and we're on top of it as much as possible. And I say that to my family and friends at home as well. This COVID thing is so out of our control in some ways, but actually the people that have the most control and the most impact on COVID are actually the people staying at home. And I and my colleagues can do everything possible to prepare, but the people with the biggest amount of control on this, the most control on this, the most important role on this is the average person who's staying at home. I keep saying if I could run an emergency department for a week from my third floor, people can stay at home.
Good point. Tell us about, everybody knows that the doctors and the nurses are amazing, but it takes more than that to run an emerge. Tell us about some of the unsung heroes who are doing special work with you there.
Okay. So I want to start, can I tell you stories? I want to tell you about Jasmine. Jasmine's one of our frontline nurses. She takes a leadership role on shift as well. We've been struggling, has been frankly everybody in Toronto, and finding a way to care for the homeless population that right now have been swabbed, but we don't have results back. And the other day, she and many people in our department have been setting up areas where they can be isolated and comfortable and having something to eat. And she actually ordered pizza for everybody. These are these little things that make such a difference to our patients. And frankly, the mood in the emergency department, they heard that Jasmine had ordered a pizza for a bunch of homeless patients who were kind of stuck here because they can't self-isolate at home. Was just one of those moments. People do this. It's been incredible. But in terms of leadership moments, Joel Lockwood is one of our emerge docs. He worked closely with Paul Dass to develop and Linda Jackson to develop the assessment center when we had it as an inkling of an idea. Andrew Petrosoniak is an expert in education for all levels in emergency medicine, but really across the board. And he's been doing an in situ simulation and really leading our education group within the emerge. We have wellness leads. And you asked earlier about how it's affecting our staff from day one, from the very first day that there was an announcement at Sunnybrook back at January the 25th on the Saturday evening. We had our wellness people checking in with people for after their shifts. Every time there's a patient intubated now, there's a team that goes and calls them and says to them, how are you? How are you today? We know that yesterday you did an intubation and that's a high-risk procedure. How are you today? We're all looking for the signals when we can tell somebody's feeling anxious or stressed, and we're checking in with them. And so those are the wellness leads. There's all sorts of unsung heroes in the operations lead. So the issue around our patients not having a place to go who are homeless, we're actually developing a small area. And again, it's going to happen almost overnight. I think there's some people that we don't talk about often, but it's the people who clean the rooms, and they have to do really in-depth terminal cleaning so that the room is ready for the next patient coming in. And it's taking way longer than it ever did. And they're doing it, they're getting it done, and they understand the urgency of it. And they're other unsung heroes. Every single nurse that works on our floor is incredible. And it's the people picking up the phones. We are such a tight-knit group, that there's so much going on in our group.
Another important group, emerge sits there on the front line, but behind emerge is a hospital.
Yes.
So how is that working out, your interaction with the resources in the hospital, the other doctors, all the services that support you?
Yeah.
How's that teamwork going?
They're incredible because, I just got off the medical advisory committee meeting, and we have a lot of meetings with like a wider group of professionals as well. And it is such an incredible group to be working with. I can't imagine having to go through this anywhere other than St. Michael's Hospital and Unity Health Toronto. It is just incredible. So, for example, we know that there's going to be an increase, and you talked to Tom Unger yesterday, we know there's going to be an increase in those with mental health conditions and addictions potentially coming through our emergency department. So we're currently working with our addiction doctors to have them situated in our emergency department so that they will be right there at the ready while we're actually in the midst of what might be a very massive pandemic. We have, and same with our psychiatrists, we're sort of going to move to a different area so that we can use the current area down the road, and we're going to move to a different area so that they can see that. We're working very closely with Sharon Strauss and her team in medicine, as well, and Rob Sargent in the general internal medicine, as well as Andrew Baker and his team up on critical care. We have developed a lot of the same protocols, so they're consistent across the organization. When somebody gets intubated, whether it's in the emergency department, on the floor, or up in the ICU, we're all going to use the same equipment, the same plans, the same posters, the same process. This is so important as we go along. And as we've worked through that through simulation, and unfortunately through a few patients that we don't know yet whether they're COVID positive or negative, but we have been doing this for the last few weeks, and we've been perfecting that as a team across the organization. So it's an incredible group to work with. It truly is. The other group we are working very closely with is the Matthew Mueller's team and the infection control and IPAC team. We check in with them at least daily and sometimes twice a day. They're making sure that we are caring for ourselves and keeping ourselves safe, and at the same time ensuring that we have a really safe PPE conservation strategy. It's not a secret that everybody in North America and the world is worried about having enough PPE to keep healthcare workers safe. And frankly, we need to keep healthcare workers healthy in order to keep our patients healthy. And so we're working very closely to do that in a very safe but conservative manner.
So, Carolyn, thank you very much. I mean, actually, anybody listening to this is going to, I think, gain a tremendous amount of confidence that St. Michael's Hospital and the physicians and the leaders, and you're a great example of that, are really stepping up to this to give us the best possible outcome that we can have. So on behalf of all our listeners, I want to thank you for what you're doing and what you're going to be doing going forward. It is tremendously reassuring to have you there. So thank you, and best of luck. I guess we can use a little luck with all of this as well. Thank you.
We definitely can, but thank you to you, and frankly to all the people who have been supporting us. We have been hearing the support. We really have. I'll also say, I don't know if you're aware of this 7:30 p.m. banging on the pots thing that happens in some neighborhoods across Toronto. But as somebody who was sitting upstairs, stuck upstairs, it was important to me. But I'll tell you, for the kids of the healthcare workers, that moment is huge. And that's what I'm hearing from my friends who have kids standing out on their porch at 7:30 or on their balcony. Those moments are huge for those kids. So if you're not doing it for me, do it for my kid. And those are great, great things that happen too.
Wonderful. Thank you so much.
And that's it for this episode of Facts from the Frontlines. To stay up to date and access all of our episodes, visit stmichaelsfoundation.com/COVID-19.